Thank you for the opportunity to present this work today, and thank you for staying till the very end. So I've got no disclosures. So the biliopancreatic diversion with duodenal switch, or BPDDS, is considered the most effective for sustained weight loss and comorbidity resolution. It has several advantages to other bariatric surgeries like the bypass and the sleeve, a lower marginal ulcer rate compared to the bypass, and lower rates of weight regain compared to the sleeve. Despite these benefits, it still only makes up less than 1% of bariatric surgeries performed in the United States, with many surgeons reserving this operation for patients with a BMI over 50. So some of these concerns include nutritional deficiencies as well as protein-calorie malnutrition. And in the literature, there's a reversal rate ranging between almost 1% to almost 5%. In addition, there is also varying techniques in terms of how people do this operation. So there's common channel lengths varying between 50 centimeters to 100 centimeters. The rule limb varies from 150 to 200, and even the way people make the sleeve gastrectomy varies. So people are using anywhere between a 34 French bougie to up to a 60 French bougie. So our objective was to assess the safety of BPDDS in patients with morbid obesity, defined as a BMI over 35 but less than 50, with a very specific technique. So at least 150 centimeter common channel, 150 centimeter rule limb, and a sleeve gastrectomy created with a 60 French bougie. So this was a retrospective review for patients who underwent BPDDS with a BMI in between 35 to 50 from 2016 to 2019 at a single institution. There was up to 5 years of follow-up for this cohort, and variables were compared with using a pair t-test, chi-squared analysis, or repeated ANOVA where appropriate. So the operative technique, all surgeries were performed laparoscopically by a single surgeon. Again, the sleeve gastrectomy was created with a 60 French bougie, 5 centimeters from the pylorus, and the measurement of limb lengths was used with minimal stretch with a laparoscopic instrument marked at 10 centimeters. Both the duodenal ileostomy and the ileostomy anastomosis was created with a linear stapler, and the common enterotomy was sewn closed. So in terms of our patient population, so 45 patients, average follow-up was just shy of 3 years. Average common channel lengths, 158 centimeters, rule limb lengths, 154 centimeters. Average age was 40 and predominantly women. And we had about a 10% current smokers at the time of surgery. And you can see the rest of our comorbidities listed there. In terms of 30-day mortality and morbidity, so we did have one patient that required early reoperation for a bleed and ultimately died from multi-organ failure and a sleeve leak. Excluding this patient, who had a very prolonged hospital stay, the average length of stay was just a little over 2 days. 2 patients presented to the ED for nausea and dehydration, and 1 patient was readmitted for a delayed contained leak at the duodenal ileoanastomosis that resolved after a couple days of bowel rest and antibiotics. And there was no marginal ulcers for the duration of follow-up. There was significant sustained weight loss out to 5 years. So at the table at the very bottom, we have detailed the number of patients that are eligible for follow-up at each year and the number of patients that were actually followed up. So out to 5 years, you see we only have 7 patients eligible, but all 7 did follow up. So in terms of average BMI change, we saw about a 14-point difference. Percent total weight loss, about 30%, and percent excess weight loss, about 70%. So comorbidity resolution for diabetes, high blood pressure, cholesterol, and obstructive sleep apnea, the majority of patients had either improvement or resolution. And if you notice on the reflux, so of the patients who had preoperative reflux, 40% resolved, 60% had no change, and we had about 11% rate of de novo reflux. So even though we're making the sleeve bigger, it's still a slightly refluxogenic operation. And there was one patient who had Barrett's, esophagus without dysplasia at pre-op, and out to 5 years, it had progressed to high-grade dysplasia. In terms of nutritional deficiencies, so there was no hypoalbuminemia, there was no limb length revisions or need for parenteral nutrition for protein-calorie malnutrition. 3 patients did develop new anemia. And in terms of vitamin deficiencies, we had 32% of patients did have vitamin D deficiency. Of those, 60% had vitamin D deficiency preoperatively, which after the DS, it made it even harder to replenish, and about 25% experienced zinc deficiency. So in terms of limitations, this is a small sample size, and because it's a retrospective review, there is potential selection bias. So patients who are more likely to adhere to a very strict vitamin regimen may have been more likely to have been offered the DS and accepted it. Additionally, available nutrition labs were less than 50% after 3 years of follow-up. And with a follow-up of just shy of 3 years, we really need longer-term data to really understand the effect of BPDDS and nutritional outcomes. So in conclusion, the BPDDS can be very carefully considered in patients with a BMI less than 50, using at least a 150 centimeter common channel length, a 150 centimeter root limb length, and a sleeve gastrectomy created with a 60 French bougie. There was sustained weight loss out to 5 years of follow-up, no protein calorie malnutrition, and no marginal ulcers. Vitamin D deficiency and zinc deficiency did remain a challenge, and so really careful patient selection and a thorough risk-benefit counseling is required to offer this operation for patients with a less than 50 BMI. Thank you. Questions?